Does it hurt when you right when you start peeing or when you're wiping, or does it hurt when you stand, or does it hurt like 5 minutes after? It really matters how we're asking the questions, and
Hmm.
it matters how you're able to feel your body.
Today, I'm speaking with Dr. Mallorie Hopkins and Dr. Allea Frances, who are both doctors of physical therapy. Dr. Mallorie is also a herbalist. Their own experiences with pelvic pain began their journey to their current practice. Dr. Mallorie is passionate about exploring the intricate connections between physical, hormonal, and emotional health in addressing unexplained chronic pelvic pain. Dr. Allea has extensive expertise in managing highly intricate pelvic floor dysfunctions, including pudendal neuralgia, pelvic organ prolapse, and chronic bladder pain. We've collected a lot of questions for our community for today's chat, but first I wanted to thank you both for sharing your time with us.
Yes, thank you so much for having us. We love sharing our passion, our work with everyone.
We'd love to start with some more about your own stories and how you ended up in this line of work.
Yeah, I'll go first. So I was diagnosed with interstitial cystitis actually when I was a teenager. I was having chronic like the chronic UTIs, no explanation why. And that carried me honestly up until I got into PT school until my first pelvic health rotation. And honestly, that was just luck of the draw. And then I was with my clinical instructor, and when I got into the clinical, I was like, oh, this is going to be pregnancy, postpartum, kind of what we think about pelvic floor PT.
Mm-hmm.
We're treating pelvic pain, bladder pain. I was like, oh my gosh, this is me. And so I got treated, and then I got better, and I started to realize, I was like, wait, a lot of this is musculoskeletal, a lot of the tension that we're holding. I mean, years of pain. And so that just put me on a trajectory, like straight into treating pelvic pain in physical therapy.
Yeah, I can imagine that would have been quite the journey, especially the realization once you got to that point.
Yeah.
Yeah, and then on my end, I mean, pretty similar. I had painful periods ever since I started, GI issues, constipation, stuff like that. But I started to use more of nutrition and more of that route. I didn't know there was a pelvic floor field, to be honest. I was a physical therapist already treating an orthopedic world,
Mm-hmm.
sports, typical injuries that we see. It wasn't until I started reading more books about hormone health, I was like, what in the world? And from there, I mean, my mom has endometriosis, interstitial cystitis. My sister suffered from infertility. So it was just a mix of women's health that
Mm-hmm.
I was experiencing that once I knew there was a field, I was like, this has to be it. I have to do this. So I'm drawn into it, and we're so passionate about it.
Yeah, a lot of what you mentioned, well, everything you mentioned are things that we hear from our community. So a lot of people with chronic bladder pain or chronic UTI have many other overlapping or comorbidities. And so many people mention the gastro symptoms as well as pelvic spasms and different types of pelvic pain and just other symptoms that are never really like officially grouped with UTI, but so many of them go together. But I think a good way to start the interview would be for you to provide us with an overview of the muscles that do make up the pelvis so that we can kind of visualize how the bladder sits within that.
Yeah, definitely. Got my pelvic model right here, so that way we
Perfect.
can have a good reference. So if I were sitting down, right, this is what I would look like. I have my two waist bones. These waist bones come meet at the middle of the pubic symphysis, and then all of the red are the pelvic floor muscles.
Mm-hmm.
So these muscles right here that are more superficial, they're right behind the vulva. They are external. And so I often look at these muscles when it comes to frequent chronic UTIs, any kind of urinary tract pain, because these muscles right here, you can see the close relationship with the urethra right
Mm-hmm.
there. And if these muscles get really tight, that can cause restriction with urination, inability to completely urinate, even pain around around these structures can cause like that clitoridynia, which is clitoral pain,
Mm-hmm.
or vestibulodynia, which is right here. So if these muscles are again are really tight, that can affect urination, and they're superficial. Now we have the more deep pelvic floor muscles. So these are the internal muscles. So just for relationship purposes, we have the bladder that sits right behind the pubic symphysis, and then the uterus takes a nice bow over the bladder. And then the rectum is kind of hard to see. And then the rectum sits right behind all of those organs. So it's a really close-knit bowl. Now we have the pelvic floor muscles. Again, they're all of the red. So if you see these muscles that attach right behind the pubic bone and they come in and attach to the tailbone, I think of those as like the classic Kegel muscles. So main function, storage and elimination of bowel and bladder. Now, if there's dysfunction in those muscles, it's going to make storage, elimination difficult, painful. Now we have these muscles back here, and they are the deep part of the pelvic floor, and they help lift up the pelvic floor. They're named the levator ani, and they are named for exactly what they do. They lift the anus. And so again, if those muscles are tight or dysfunctional or uncoordinated, it's going to kind of throw off that whole bowel bladder system as well. So that's superficial, deep, and then even that backside posterior view where it's coming in, attaching onto the tailbone, attaching onto those bottom aspects of the sacrum, which is sometimes why we can get that SI dysfunction coming in with as well. And then we have this close relationship to the hip joint as well. So that's kind of how it's all interconnected as well. So we got low back connections, hip connections, and then all of the visceral organ connections as well.
It kind of helps explain why it's often difficult for patients to pinpoint where pelvic pain is coming from. It's all so connected. But how would you go about establishing where the pain might be coming from, the vagina or the bladder area or some other muscles in the pelvis?
Yeah, so typically when someone comes in, we're already trying to get that wheel turning with descriptors. So they might say something like rawness or burny or achy or sharp or deep, or they might say clothes bother. All that is already making us think, oh, maybe it's superficial, maybe it's deep. If someone said it hurts during bowel movements and it feels like a knife is shooting up to us, it's like, oh, okay, we have to look back, not front first. So there's a lot of different ways to figure out where it is. And sometimes it's hard because when you come in, it's hard for you to even explain what's going on. So from there, we kind of guide. It's like, okay, if they can't tell us where it is, and they're like, oh, it's kind of like this, I can't really pinpoint it, then we're going to start asking the deep questions like, okay, does it hurt when you right when you start peeing or when you're wiping, or does it hurt when you stand, or does it hurt like 5 minutes after, or does it hurt after intercourse? Does it hurt during intercourse? So it really matters how we're asking the questions, and it matters how you're able to feel your body. And it's okay if you don't know how to feel it. We teach you how to feel that.
I think it can be really difficult to differentiate those symptoms. If you've had chronic inflammation because of infection for a long time, everything can just feel like it's in pain. And we often get the question, how can you tell whether the pain you're experiencing with urination is because of infection or if it's because of a pelvic floor issue or ongoing inflammation? Is there a way that you can differentiate?
Yeah, there are ways that we can differentiate too. So, can you ask that question again?
It's about how to know whether pain you're experiencing with urination is infection or a pelvic floor problem.
Yeah, so if people are confused what they're having, I mean, I go through this weekly with patients, and I was just having this conversation last week. And so if it's first off, I say go get a test. You can go to CVS, or if you have a good relationship with your urologist, urogynecologist, sometimes they'll give you samples. Send that in. Let's just get a confirmation. However, by this point, we've established that there are symptoms that are related with the pelvic floor. So the first one is, are you constipated? If the person's constipated, I think, well, this potentially may not be an infection. This may be the bowels that are pressing up on the bladder. Therefore, the pelvic floor muscles are getting tight. There's unique symptoms from person to person, but it would be they're not having trouble with completely eliminating. They're able to completely eliminate the bladder. And maybe it's a little stingy whenever, like that burning sensation afterwards. So I guess to answer your question, it's dependent on
Hmm.
the person. But I would say, are their symptoms consistent with their more pelvic floor symptoms or with the UTI? So when I think UTI, I think of like fever, malaise as well. But also something is a little like clinical tip for me is if heat does not make it better. So if you have a
Hmm.
UTI, heat will often flare your symptoms, and you will not want any heat in this area because it's a true infection. So if I think there's heat on this area and it's making it worse, probably an infection. But if it's starting to cool things down, I would think this is probably more pelvic floor, more structurally related.
That's
Yeah.
interesting because a lot of people do say they like to use a hot water bottle when they have UTI pain. Does that mean that you think that might actually be more of a pelvic floor or a pelvic floor reaction to an infection if they do have an infection present?
Yeah, I tend to think so. Like if it's an acute infection, it's not going to respond well to heat, right?
Hmm.
Because if there's inflammation in that area, heat's just going to exacerbate it. And so your body's going to want to think cool that area down. So that's like my first, I mean, that's my own experience too with having
Hmm.
an UTI. So I'm like, my body does not want heat in this area at all. But if I am having symptoms, I'm like, oh, he's kind of like dropping those symptoms down. I'm thinking this may not be a UTI.
Yeah, to add to
Okay.
that too, it's the intensity. So if you get moments of silence of those pain signals, it's most likely musculoskeletal. If
Okay.
you're not getting any moments, like it's just raging, that's more likely a UTI. It will not get better as the days go on. It will actually get worse. So sometimes I tell people, give it 24 hours. If you feel it like riding a wave, then most likely it's going to be musculoskeletal. But
Hmm.
again, like you are sleeping by that toilet, you're just like, ow, what is going on? That's a UTI. And then the second thing is more like, what are your thoughts? So if you start to think, is this a UTI? Is it not a UTI? Most likely not a UTI. Sometimes when it is actually a UTI, you can't think, you're not
Mhm.
here, you're just in so much pain.
Hmm.
That's another way to kind of think about it on the inner self, or like, what are your thoughts?
Okay, that's an interesting way to look at it. And sometimes the symptoms that people report are not pain. It could be an idiopathic itch or a tingle or something that they get. And I got a few questions about why that happens and then how you would approach that from a physical therapy point of view.
I think that, yeah.
Yeah.
Okay. So this is what I I always say too. So we have the pudendal nerve, and the pudendal nerve, I geek out about this nerve. So it has three components. It has a visceral component, which means it innervates our organs, and then it has a sensory component, so that it gives us sensations. And then it has a motor component. And so that means it's in charge of how our muscles are contracting. And so this is what makes pudendal nerve a little tricky because it's giving off so much input and receiving so much stimulus as well. So if so the sensations of the pudendal nerve are burning, itching, arousal, right?
Hmm.
So your pelvic floor, so let me take the organs out. So if we have the pudendal nerve coming in right through here. If these muscles get tight, it can constrict on the pudendal nerve and it
Hmm.
can elicit those organ sensation motor functions, but oftentimes it's the sensation that can be affected. So it may give off that burning feeling, it may give off itching or even unwanted arousal. And so sometimes that's where the burning is coming from too. But there's also another branch of the pudendal nerve coming in, innervating right at the base of the vagina and up at the clitoris. And so this is something often I see as well when people are having urethral pain. I say point to it. And
Hmm.
so a lot of the time, because the clitoris and urethra are stacked right on top of each other, people point right to their clitoris. I'm like, oh, That's your clitoris that is giving off that burning sensation. And
Mm-hmm.
like you were saying earlier, whenever those pain signals are so diffuse, it's coming in and it's giving that general area burning. And so I think pudendal nerve,
Mm-hmm.
itching, burning.
Yeah. Additionally, when we think about the vulva, it's lined, or I guess let's just say estrogen supports these tissues.
Mm-hmm.
And so also with the urethra, estrogen, but testosterone as well. So if people are saying they're feeling itchiness, other things I'm thinking of is hormonally what's going on. Do they have low hormones? And then I might
Mm-hmm.
ask in that nature. But then secondly, tissue dryness. So if you do have low hormones, or maybe you're just cyclically going through your cycle and towards your luteal phase, you start to notice that you get a little bit more itchier, a little bit more UTI symptoms,
Mm-hmm.
then we're that there might be a hormonal imbalance influencing these tissues. And then if there's dryness, we teach mobilization techniques so we can help them soothe that tissue, bring more blood flow so the itchiness can quiet down a little bit.
On that
Okay.
note, when people are wiping a lot or trying to keep that area so clean, it's
Mm-hmm.
often, which is
Mhm.
kind of goes in with what Mallory's saying. So looking at tissue, nerve as well.
Okay, we do have some more questions about nerve pain, but first it would be good to have a walkthrough of what it looks like. So if a patient was to come to your practice with unidentified pain or unexplained or unlocatable, what would be the steps they could expect to go through in order to get a diagnosis, and what might a treatment plan look like?
So first step is obviously finding that right practitioner. Wherever you are, there are directories that you can look up. In Europe, I don't know, but over here we have Herman and Wallace and Pelvic Guru. Those are directories that people are registered under, and
Hmm.
you can look at your locations. Now, when it comes to when you come into the clinic, first thing is we're going to take a subjective component, meaning we're going to listen to your story. Think about it as being body detectives. We're here just listening, trying to put the pieces together for you. So as you're talking, we're just going to kind of write some things down, ask specific questions, categorize that. After that, we're going to do hands-on. Maybe we're going to theorize what's going on and then look at your body and start putting those pieces together. And from there, typically I tell people it takes at least 6 sessions for us to get to know you, your body, the way it's responding. Unfortunately, when it comes to pelvic health, there's no protocols. There's
Hmm.
no, when you come in for shoulder pain, right? It's like we have these specific measures. We can take you through each series. We can tell you when you're going to get better. When it comes to pelvic health, it's very big on collaboration. We're making sure we're talking to you, we're communicating with you, very transparent and honest. And then we're getting you to the right practitioner because unfortunately, we get people who have seen many different
Hmm.
providers and everything is you look fine, you look normal. And when it gets like that, I often tell people, I'm so sorry that you're experiencing that, but I'm happy to hear that because that shows me there's no disease, there's no damage. It's just musculoskeletal and or nervous system hormonal things that we can't see. And so
Hmm.
since we can't see that, we often are the providers to be able to help them, guide them through the medical field and tell them where to go. Now, if we're thinking about diagnoses, it really depends. I give people options because sometimes you don't need the diagnosis in order to get better.
Hmm.
Sometimes you do need the diagnosis. So there's a big thing when it comes to interstitial cystitis. And the biggest thing we want to know is, are there Hunner's lesions? Are there actual damage to your bladder? If so, that's a whole different case. If you don't have lesions in your bladder, then we can take you the conservative route. And if you do have those lesions, we do have to add more medical route, making sure you're getting that lining nourished and it's not so inflamed and spiky and just yelling the whole time. So there are different paths. And so urogynecologists are the people typically we would refer to for
Hmm.
that.
And if someone has an active infection, is it inappropriate to get pelvic floor physical therapy at that time? And how does that apply to people who have a chronic infection that just never really gives them relief?
Yeah, this is how I practice. So whenever someone comes in with an active infection, I will not do internal PT just because I do not want to cause any more friction, movement into that tissue. I really want it to rest and heal. We can still move. So usually I would say, just stay at home. I don't need to see someone during an active infection. I want them to rest, stay hydrated, take whatever course, their physician has prescribed to them. But when it comes to a chronic UTI, I will like see people, whether that's telehealth consultation or they're in the office, because we need a game plan. What's happening? What's going on? Again, like what Dr. Mallorie was saying, we need to look at your tissue. We need to look at your abdominal wall. What's going on with bowel movement? So there's two different courses. Active UTI, we're taking a little break until you do not have a UTI. If it's a chronic UTI, that's where we have to game plan because something is keeping this going. So, yeah.
And that's kind of the next question was about patients who are on long-term antibiotics. You already mentioned that you work with clinicians in other specialties to help get different types of treatment that might be necessary. How do you think that long-term antibiotic treatment or other chronic UTI treatments can complement pelvic floor physical therapy?
Yeah, so when it comes to long-term antibiotic use, I think the question more so, are you asking how does that impact their GI system or maybe their vulvar tissue or just general? Are you asking more so like pelvic wise?
I
Because
think
I would go first route.
Yeah, the former is quite interesting because people often have the question of how does it affect long-term health for one thing, and there's also often the question of do pelvic floor physical therapists even think that antibiotic treatment is necessary? But I understand that that's kind of outside what you do, especially if there is an infection present. So what you mentioned is quite an interesting way to answer that.
Yeah, so if someone's on antibiotic use, we always say just confirm, get the culture first. So people are, just prescribed antibiotics unknowingly if they do have one or not because they have the symptoms. They do the dip test and the test comes back positive inside the clinic. And from there, they're given antibiotics, but then they might get a call back 3 days later saying like, hey, actually, you don't have a bacteria present. And so they're prematurely taking antibiotics. So in that case, I tell people if you can, because I know it does help, wait until you get the confirmation and then start taking it. But number two, the most important thing is if you're prescribed it and you don't want to take it and you do have an infection, take it. Because the worst case scenario is it goes up to your kidneys. We don't want that. And from there, it turns into sepsis. So take the antibiotics. It's very important. Now, if you're long-term use antibiotics, I would start going down the herbal route and trying to see like, is there any way we can support your tissues, nourish it from a different perspective, especially if you're not in that chronic state of that UTI right now. Like if the UTI is not active, it's being proactive on the other side of the story that can help nourish the tissues. So yeah, that's kind of how I would look at it.
I can piggyback too, just from a person who was on long-term antibiotics too, which developed into a biofilm. And I know that happens with a lot of chronic UTI, right? You have that resistance in the bladder. And so I feel like what Dr. Mallorie was saying with the herbalism, I feel like the herbalism is absolutely critical at that point to heal the lining of the bladder to help, because at that point, your body's not responding to the classic antibiotics. And so you have to disrupt that in somewhere. So yeah, I fully support herbalism when it comes to chronic UTIs and biofilm presence.
And when you say herbalism, is that aimed at fighting an infection or inflammation or providing another kind of support?
It's support. So if you have an actual UTI, herbalism won't work. At least that's the way I view it. I'm sure other herbalists take a different approach, but to me, herbalism is more of this patience and it takes its time and it works it through and it makes the changes long term. Again, when it comes to antibiotic use, that means you have UTI. We want immediate things. And that's the beauty of medicine. It gives you that very quick experience. We don't have time to nourish, but we can do both. We can nourish at the same time as you're taking action of resolving the actual bacteria that's involved. And then after, we can work on how can we prevent the bacteria from building up in the first place. So it's
Hmm.
kind of working with and then moving forward to prevent it to happen again. But once it happens, it's switching gears and trusting that your body can take the antibiotic.
I think it's important to talk about that kind of support as well, because I'm sure you're aware of the limitations of standard testing for UTI. So a lot of people don't get an answer. Standard culture has a lot of limitations. Dipsticks are very inaccurate. And so they can often be in this place where they're sure they have an infection, but they cannot get the right treatment. We have a lot of other information on our site about that. But that does mean that trying to support overall health of the bladder while they're trying to find a better way forward becomes even more important. And we do have a couple of questions based on some of the experiences that people have had through their treatment or just through having UTIs for such a long period of time. One of them was, can pelvic floor physical therapy help with a distended bladder? Can you actually correct something like that over time?
Yeah, so the bladder, we got the bladder right here, and we can see all those strands on the bladder, and that is a muscle. It's the detrusor muscle. So I will say this, not once an organ is distended in other areas like the colon, it's probably going to stay distended. However, the bladder is a muscle. And so we can get that stretch because it's elastic, right? So it can
Mhm.
come down. But really, the big thing is from a neuromuscular level is that our bladder is dependent on this threshold. And so whenever the bladder fills, right, to that 700 milliliters, where it's a completely full bladder, that can reduce if someone's having chronic pain or those chronic UTIs, that threshold can go down. So that can also be help with the distension of the bladder and the sensations that we feel. So to answer the question, yes, the bladder can we can resolve some of that distension into that, but also from that neuromuscular, that coordination level between your brain and bladder, we can increase that urinary threshold.
Okay, that's very interesting. Another comorbidity that exists a lot in our community is endometriosis, or unrelated to endometriosis, painful periods. Can therapy help with painful periods?
Yes, 100%. When we think about period pain, many people just think about just hormones. And there's so many connecting factors. Do you mind if I?
Yeah.
So, like Dr. Alley was showing, the uterus sits right here. Now, what hugs it on either side is a muscle here, and on both sides, it's hugging it. So that's called the obturator internus. So when you think of period pain, the first thing I want to ask someone is, where's your period pain? Some people might have lower abdominal pain. Some people have pubic bone pain. Some people have low back sacral pain. Some people have pain radiating to their inner thigh. And then some people have vulvar pain and vulvar spasms.
Hmm.
So depending on all that is the way we're going to look and treat it. For example, if someone's having lower abdominal pain, I want to know what the uterus is doing. Is the uterus stuck? Is it sticky? So then I look at the uterus and I try moving it. It's like, ooh, it's a little bit tight here. All of our organs are tethered down by ligaments. So we want to look at the ligaments. The ligaments all attach to the sacrum for the most part. And so then I want to look at the sacrum. Is the sacrum tilted in a way? So we look over here. Is the sacrum tilted in a way?
Hmm.
The next thing we want to look at is maybe tailbone. If the tailbone is pushed forward, uterus is right there. So is the tailbone being pulled forward by either the sacrum or the pelvic floor because it's lifting and it's tightening that area? When you're on your period, your uterus does expand. And so when it's expanding, it could feel just tense and tight. Doesn't want to feel that. Next things are nerves. Nerves can also refer down into the inner thighs. So that's something I'd want to look at too, like what's going on back in this area. And it'll look like this with the muscles back here.
Hmm.
So these muscles can be tight, causing irritation to those nerves. We have nerves that come to the front this way. And so that can become tight and that can be radiating down if people have endometriosis. they might have adhesions. And so if they have adhesions, whether that's through the endometriosis lesions and or the surgical component, we want to make sure that's nice and mobile. And then lastly, constipation.
Hmm.
Constipation is always something we're thinking about when it comes to any pelvic health issue because they're just so closely knitted and it can refer everywhere that we're not thinking like that. And when we talk about constipation, most people think, oh, I go all the time, I'm not constipated. It's not the frequency, it's the amount. So if people are going daily but are only going this much,
Hmm.
that much, I typically tell people, if you haven't looked at your poop, look at your poop. How long is it? And I'm like, is it about like 6 inches? Is it about like 12? And people are like, oh yeah, it's about like maybe 6 or like this big. I'm like, oh, you're not going enough. So I wish there was a study. I know somewhere in the world of my brain that 12 inches came up. And I can't confirm where that came from. I am trying to look for that source. But you basically want to be pooping around like this much daily.
Hmm.
And so you're not doing that. And it can be broken up into sessions. You can go twice a day. That's totally normal. Um, 2 6 inches.
Hmm.
That's fully eliminated. If you're not going that much, that's constipation. If you're going longer than 5 minutes, right, you have to sit and you're trying, that's constipation. If you have pain, that's showing pelvic floor muscle tension around there, which
Hmm.
is constipation. So there's just a series when it comes to period pain that we're not just looking at the source, we're looking at that big picture. And then lastly, prostaglandins. I mean, I could keep talking period pain. There's so many things that could involve in it, but our work is to support the tissues, the ligaments,
Hmm.
movement, so that we can increase endorphins and reduce the prostaglandin component, so we can
Hmm.
help inflammation and pain signals.
I'm just going to make a little visual image. This is the bladder, vagina, rectum, and they're on top of each other, right? So there's inflammation back here or constipation. You can see there's like stool pocketing right there, how it's going to put pressure right on the uterus. Therefore, it's going to put pressure on the bladder. And even if it's a little bit of pressure, that can go a long way.
Hmm.
It's lots of discomfort.
Yeah, I think a lot of people can attest to that in our community. Before we jump on to more questions about nerve pain, there was one specific question about treatment, which was that do you utilize Botox in your practice? And if so, do you find that it can be beneficial and in what circumstances?
Yeah, definitely. So my practice will always go conservative until I have to start to integrate different treatments, interventions. And so when people are stuck in that chronic state and their pelvic floor cannot get out of that spasmodic or that tightened, contracted state, I will refer for Botox. And so what's really great too is the practitioners that I work with. I will do a pelvic floor mapping assessment. And so I map out the muscles that specifically need the Botox and where those muscles need the
Hmm.
Botox. I'm going to steal that pelvic model really quick. So, right, if there's those superficial muscles that are having a really hard time relaxing, versus these muscles are fine back here. A lot of the time people go in for Botox and they'll get these posterior muscles. And that's fine because we know that the Botox can move and translate forward.
Hmm.
Um, but what's really great working with a PT who is specific and mapping out the pelvic floor, we can say, oh, actually, it's STP, superficial transverse perineal, that needs Botox. You actually need some Botox right at the perineal, right at the base. And then maybe these more superficial pelvic floor muscles versus the deep. And so, yes, I will recommend Botox for the people who are having a lot of difficulty with the coordination of their pelvic floor, relaxing their pelvic
Hmm.
floor. With that, sometimes can come some difficulty holding back urine, holding back gas in those first few weeks. But I always say it takes about 2 to 4 weeks for Botox to set in. And the most important part when it comes to Botox is you receive pelvic floor PT. in clinic or you do it at home because you have to now retrain the muscles. You just paid a lot of money to get the Botox. Now we need to make sure that it works so you don't have to keep going back. And that's the point of Botox, not to just relax it, but now
Right.
let's retrain the system.
Yeah, that makes sense. And you spoke earlier about why the pudendal nerve is so involved in all of this. What's pudendal neuralgia and what are the causes, the common causes of that?
So pudendal neuralgia, so we'll just break that down. Here's a fun fact. Pudendal, in its Latin base is shame. So I think that's telling you a lot right there. And then we have nerve, which is the N-E-U-R, and then algia, which means pain. So essentially we have a nerve that is pain specifically to the pudendal nerve.
Hmm.
And so pudendal nerve, this is how I think of it because a lot of after working 10 years at this now, people are pudendal neuralgia and they look it up and there's not a lot of great stories. People don't have a lot of good experience with pudendal
Hmm.
neuralgia. They think of entrapment. And so the way that I like to shift the way that we're talking about pudendal neuralgia is there's inflammation to the nerve. I mean, we all have experienced some inflammation to a nerve at some point in our life. And let's say we pinch a nerve in our neck, it takes about 6 weeks, it calms down. However, when it's in our pelvis, and because there's so many sensory, those nerve receptors, and it's organ related too, it feels like it's a pretty big deal. And it
Hmm.
is. Like it can be a big deal when it's not treated or addressed, or you're kind of getting into that psychosomatic part too. So um essentially, I think of pudendal neuralgia, irritation to the nerve. It can elicit motor symptoms, sensory system, visceral symptoms as well. It can be caused by prolonged sitting. Cyclists often get it. It could be childbirth. It could be sexual trauma. It could be physical trauma. It could even be emotional trauma, thinking about its origin in the name, pudendal shame. So we're kind of dabbling in a lot of mechanisms of
Hmm.
potentiality.
Could a single UTI lead to pudendal neuralgia?
Yeah, I'm sure because I mean, if those muscles are really tight, right, it's going to compress. Let's say you get the UTI, your body is getting into that hypertonic, tightened state, and then it doesn't relax. And then the nerve gets irritated. There's not enough slide and glide. There's restriction. There's a loss, not loss.
Hmm.
There's a lack of blood flow to that area, can cause friction. And so then someone can develop a pudendal neuralgia. It may not be a long term, but it could be short term. Just again, thinking about that pinched nerve in our shoulders, our neck, our back. It it can go away. Our body has the ability to heal itself, and we just have to support that and kind of get on the same page. And education's huge.
Yeah, typically too, when it comes to pudendal neuralgia, if there wasn't no actual onset of the symptom, like it just kind of came, I tell people that, especially if you didn't change anything, your body, you want to think of your body as this kind of pillar system. So we have the way your body's posturing. So that's one, that's biomechanics. Are you slouched? Are you lacking specific restrictions within your mobility? Are some muscles tight? Then we want to look at your nervous system. So are you in a sympathetic response? Are you in a parasympathetic response? That fight or flight, rest and digest. You want to think about that hormonal system. All these things within our body all have pillars. So, for example, when it comes to pudendal neuralgia, down here, this is our pelvic outlet. And these are our sit bones. So Dr. Ali mentioned about sitting for too long. So
Hmm.
how could one person sit for too long and be okay, but then another
Hmm.
person not? So it's the act of sitting is a contributing factor, but it's the way our body's posturing that can put us more susceptible to getting things like this. For example, if these are our sit bones, this is a pelvic outlet, this is internal rotation. So you'll see that these two bodies are coming together. And then we
Hmm.
have external rotation, which makes it go away. So if someone's already lacking internal rotation, meaning they're already very compressed in this state, pelvic floor is probably a little bit more shortened. So now this person sits, and let's say they're sitting back here, they're not sitting on their sit bones, then they're adding more pressure to this system, causing right here, pudendal nerve is where it exits out of the pelvis and goes into its area. That's when sitting is going to cause the issue of creating pudendal neuralgia. So that's just like things to think of. Is your pillar, where are those pillars? Where are we at when our body is having these symptoms? And those are things to look into, right? Are you having big things happening in your life? Going back to the emotional component, there, if we think about energy systems, if we just think about what is in this area, you can think of it energetically, more of
Hmm.
like the root chakra, sacral chakra, right? Protection, when she was mentioning trauma, right? So if we feel threatened, this area of our body is going to be very protected, very tight. But if we think about nervous system, that fight or flight response, our pelvic floor is very automatically driven with the autonomic nervous system. So if you are trying, if you're nervous, if you're fearing, if you're worrying, right, the bladder carries worry. And so if you have those emotions so stuck and so stagnant, our body's super smart. It protects us. It's not going against you. It's going for you because you're feeling those emotions. So it's going to turn on. And so that's where all of those other symptoms arise. So other things to think of when it comes to the body.
I mean, there's so much to think about, which is why this is so difficult for people to move forward. But one of the things that people often describe is just the pain is not there and then suddenly it's there, or it's there and it disappears when they just drink one sip of water. Like, how can we explain it when there doesn't seem to be any logical explanation for this coming and going of the pelvic pain?
Nervous system. When it's like that, if it's very sporadic, it started here, now it's here. It was there like this, and now it's like this. If it's constantly changing, it's nervous system. And
Hmm.
not nervous system in a way that we're overthinking and it's all in our head. It is not. The body is so amazing. Our nervous system, like I said, protects us. And so if there's any ounce of worry, maybe you even think like this water is like, I'm very thirsty, I need this water, and you drink it, our nerve system's like, I can kind of like come down now. So you are not thinking that, but your body is, and your body responds. So that's a way to always kind of take a step back. If it's changing for you, start working on that nervous system. See what's going on deep and within. Look around you. What's going on in your life? Is it heavy right now? But also, pain is worrisome. And so when we think about pain as physical therapists, that is our specialty. We are pain experts. We work with pain day in and day out. And it's one of the biggest things that, we take pride in. And on my end, I love teaching people about pain, how to befriend pain, how to meet pain, and what does pain mean to you? And how can we reframe what pain is? Because again, it's just our body trying to say something. And the frustrating part is because you, as a person experiencing pain, do not know how to read it or hear it or listen. So that's
Hmm.
why you seek the providers that can help you interpret it. And one of the best things to learn is that once you find a really good provider that you connect with, let them hold it for you. Let's take the weight off of you and let us hold it for you so that you can actually just do the things instead of have to think about what is going on, because we're going to teach you that. So I hope that for everyone, that they can find a really good practitioner that they really connect with. And if you
Hmm.
don't, there are people out there. So it's like, just keep searching. I know it's frustrating. Reach out to us. We do virtual stuff. We can connect. I just feel like you need to find that person that makes you
Hmm.
feel and safe too, because nervous system, it's part of the treatment.
Yeah, it's so important. It really does help when you find that right clinician with whatever treatment you need to move forward. But one of the questions that comes up a lot with this is so painful, the pelvic pain that people are going through with UTI. Is it normal when you start pelvic floor physical therapy for the pain to get worse? Or is it like, how do you know when the pain is not necessary for future improvement?
Yeah, so sometimes it can. And so it kind of like is piggybacking with what Dr. Mallory was saying, because as we're peeling back these layers, we're really coming up and getting familiar with your pain. That can be a really uncomfortable process. And there is that aspect of getting familiar with your pain, but there also is what Dr. Mallory was saying earlier. It takes sessions for us to get to know your body.
Hmm.
We're doing a full body assessment, and sometimes we're making you do things that provoke your pain because we need to see what you're doing at home that may be contributing to this pain. We may be poking on certain structures because we have to find what structures are involved with the pain. And once we have that map down, then we can start to cool it down. So essentially, we're looking at this like a map and we're pinpointing, right? Hot spot, hot spot. Oh, this is actually a relieving spot. And so, in an ideal world, we would love for everyone to come in and start to feel better immediately.
Hmm.
And sometimes that does happen, and sometimes it doesn't happen, but both are good. Information and data points are what we need to get people to being pain-free. So it's kind of part of the game. I mean, I think about other injuries as well when you're rehabbing an ACL, when you're rehabbing a frozen shoulder, there's going to be pain that's involved.
Hmm.
And I always say too, this is a time that we can actually capitalize. Like, how are you responding to pain right now? Let's practice this together. What are these techniques that we can start to get your pain down in the office versus when you're at home and you start to spiral? Let's put in those strategies now. So I always say, actually, this is a good thing that we're provoking pain right now.
Yeah, and another thing to acknowledge is how long was the aftermath? So if
Hmm.
someone comes in and they said, I left the session, I was feeling very achy, like it was coming on again. And, when I woke up the next morning, it went away. I'm like, oh, great. That's exactly how I want it, right? You don't want to be agonized. But then, it's not uncommon that someone will come in and be like, I literally, and we see them once a week. They're like, I literally just got relief yesterday, last night. I was like, oh,
Hmm.
wow, you had discomfort for a whole week. And they're like, yeah. I'm like, all right, we're going to reel it back. This is what we did. Now, this time, I'm going to tone it down, look at different areas, and let's see how you respond. So we're constantly adjusting with people, trying to see like what's the best touch, what's the best area. Sometimes, like Dr. Ali was mentioning, if it's a hot spot or like, oh, this is actually relieving, we might be like, okay, let's let those hot areas calm down on their own. We'll work on the places that you find relief. Or maybe we start up at the neck. I know that sounds like what the heck, but if you're having pain down here, we can address the nervous system in this area.
Hmm.
Like maybe right now your body cannot get the touch in that area. We'll work our way down. We'll make it that your body receives what we're trying to do. So we'll keep trying to figure it out. But our goal is to never have someone to be in pain for a week. If you're in pain for a week after the session, something we have to think about.
Hmm.
If they're in, I usually use, in exercise science, DOMS, delayed onset muscle soreness.
Hmm.
Um, when you go, let's say squat and you PR that day, you're just like working really hard. You're going to be sore for about anywhere from 24 to 72 hours. So that's a time frame I give people. On a sore end, 24 is great, 48 is good, 72 is like I just pushed your limit. And if
Hmm.
it's past 72, that's way past the limit. We need to bring it back and figure out a new route to help you.
Okay, so let's talk a little bit about painful sex, which is a big topic in our community as well. How can pelvic floor physical therapy help with that, especially if it's a pain that only comes on after sex, so it might not be there when you're in therapy?
So many things. I, well, this is another topic we love. Um, let's talk about UTIs specifically. So people who get UTI-like symptoms post-intercourse or postcoital, we want to think about what positions were you in? When did it happen? Was it before and then it exacerbated? Was it during in a specific position? Was it when you orgasmed? Was it when they touched you in a way? Did they put their finger inside of you? Were they fingering you, right? Did you have it after you peed? Did you go pee before you had intercourse? And then
Hmm.
you forced yourself after your 20 minutes of intercourse to go pee again,
Hmm.
right? That can trigger it because you're going pee so close to each other, right? And then you can think about the actual components of it, which is it actually UTI? Do we have to look at your pH levels and your partner's pH levels? And are you guys just not connecting on that end, right? Is there actually UTI going on in there? Chances are it's probably the others that we just mentioned versus the actual UTIs being caused by intercourse. And so when you're having intercourse, just the mechanism, if you're having penis and vaginal intercourse, penis goes inside vaginal canal, but as you're becoming aroused, your vaginal canal lengthens. So it's called vaginal tenting. So it's going to lengthen. And then right here on the back end, this is going to be your cervix. This is going to be the uterus. It's supposed to lift up and out of the way.
Mhm.
And then you're able to penetrate. Now we're thinking about, remember, pelvic floor muscle tension. So if those muscles are tight around, right? If they're already tight and then it can't do the mechanism of lengthening and moving, well, now it's crowding in there. And your partner who's penetrating and the person that you're having penetration intercourse with, it's going to be causing more friction in those areas. Bladder sits right on top. So if you're in missionary, your body's going to look like this. And so bladder's right here. And so what you can think about is if everything's not moving up and out of the way, well, then it could be irritating the urethra that sits right behind that pubic bone. So you'll see this muscle right there,
Mhm.
right on the outside. Can you there? Yeah. This is what those two muscles look like. Let me see. Okay. I'm trying to see how I can show you. Okay, so that's how the two muscles look like. Urethra is right in between. So
Mhm.
if there is right in between that, and those muscles are super tight, as you're having penetrative intercourse, it's basically like there's so much friction in there, and it's not allowing that kind of gliding motion. So when we think of pelvic floor muscle dysfunction, if someone's saying they're having pain, painful UTI, or like urination post intercourse, we want to look at all those pelvic floor muscles. We want to see, can the uterus move back? Is the cervix moving back? And then getting more detailed, like with the orgasms and different types of ways people have pain.
Right. And on the topic of penetrative sex or penetration in general, there has been quite a bit of discussion lately about how vaginal penetration is essential to help prevent vaginal atrophy. Can you provide any insight on why that might be the case?
Yeah, so essentially, muscles act like any other muscle in our body, or our pelvic floor muscles act like any other muscle in our body. They contract and they relax. And so, whenever we are getting movement to that tissue, not only are we getting into the actin myosin, like those contraction filaments will build a stronger pelvic floor, but we're also getting that neuromuscular feedback. So, our body says, oh, we are still using this area. So let's continue to feed that area blood flow, more coordination. So that's essentially how it works. Contract, relax is essentially needed for vaginal penetration.
Does that have to be in a state of arousal for the benefit to be gained, or can it be penetration of a pelvic floor device or a sex toy without arousal?
That's honestly a really good question. I would assume that you could do both, like just saying like a squat is going to be beneficial for building your pelvic floor. Any like running or any kind of activity is going to be beneficial for the contract relax, that full function of the pelvic floor. Um, Sex is a functional activity as well. So to answer your question, you can do both, and
Hmm.
it will benefit the quality of the pelvic floor.
And how frequently is penetration required in order to gain that benefit?
For the parameters of
Yeah. Yeah, when it comes to, I would say frequency, it's more of like what the goal is, right?
Hmm.
What is your, if the goal is to open up tissue, and if someone was like, I love intercourse, I'm like, beautiful, have intercourse, do as much as you want, right? But if someone doesn't like intercourse, especially if they're having pain,
Yeah.
it's typically very hard to prescribe something like that. So we often would give them more of like, and have you ever heard of Kiwi? It's by the Pelvic People. They created like a little pelvic pain device.
Hmm.
Well, it is more of like, think of it like a massage onto your vulva, but can also be inserted. So it kind of looks like this. It doesn't go in that deep. It's about this deep.
Hmm.
It works on entry pain. And so we might tell someone, do that daily until I see you next time. And when I see them next time, I'm like, okay, was there changes? Did they have pain? Did that change? And if that worked, I'm like, great, let's do it one more week daily. Let's see what happens. And then after that, I might have them go down to 3 times and then maybe once a week. And then from there, I mean, I know you're saying that arousal might not be there, but when you're using these devices, arousal could be there.
Hmm.
And so I typically would guide people into like, this is more therapeutic. I want you to get into your body, feel what it's feeling like, stretch it,
Hmm.
be curious. But if you're aroused, you have options. You can be like, oh, interesting, I'm getting aroused. Okay. And then you just kind of do your thing and continue stretching.
Hmm.
But if you're like, oh, I'm actually getting aroused and this feels pretty good, then I'm like, go for it, right? Arousal and orgasms lead to more blood flow, lead to more lubrication. It plumps the tissue.
Hmm.
And so, like Dali was mentioning, it is an exercise. Intercourse is one of the biggest kind of events that the vaginal tissue will go through. And so if you enjoy those things, then it's no shame. It's therapeutic.
Hmm.
So definitely something that we encourage.
I think the question partly comes from this predicament that people in this community are in. They avoid sex because it causes a UTI or it causes pain, but they also know that vaginal atrophy is a huge contributor to UTIs. So then they're told that they need to have penetration in order to benefit or prevent atrophy, and then they feel like they can't. So they're asking what is the minimum amount of penetration they can have to get the benefit without pushing them over that edge.
So many other things.
So many other things. It does not have to be
No,
intercourse.
yeah,
Yeah.
does not have to be intercourse. Like I was saying, squats, zone 2 exercise,
Stretching, actually moving your vaginal tissue, right? Like outside, not inside. There's so many alternatives.
and if you're worried about infection, like just even touching, you can wear gloves.
Hmm.
So
Hmm.
there's so many things to do besides vaginal penetration.
Yeah.
And can an orgasm benefit the well, prevention of vaginal atrophy in the same way that penetration might, or in a similar way without penetration?
Yeah. Yep. So essentially with an orgasm, it's the contract relax of the pelvic floor muscles. And
Hmm.
so not only are you getting movement of the pelvic floor, but you're getting blood flow and you're also getting a lymphatic flush, which is great for immune system, which is great for the immune health of the vaginal tissue, of the bladder, of the urethra.
Hmm.
Okay. And in terms of things that people can do at home, are there any exercises that you would consider safe that most people could try?
Hmm.
Yeah, so I always lean into first the nervous system. So we'll go into breathing mechanisms, which we could talk about that honestly for a good like 10, 15 minutes
Hmm.
to down regulation exercises, because that will help calm the nervous system. That is an exercise in its own. Your body needs restoration as much as it needs mobility. The two go hand in hand. If you can tolerate, walking is amazing. Or pain in general, there's a lot of research on movement with people's pain getting into zone 2. Again, if you're, I would highly recommend working with a physical therapist, someone who knows and is trained in exercise prescription.
Hmm.
Um, but just to across the board, meditation, breathing exercises, walking, mobility, stretches at home across the board will be safe.
Yeah, some stretches that are pretty general and like generally safe could be a child's pose, cat cow, adductor rock back, butterfly,
Happy baby.
happy baby, and then let me see that, and then actual touch to your vulva. So
Hmm.
outside, externally, not internally. You can get your labia and you can stretch so we can relieve right here. Here's the urethra, relieve that area. So hold that and stretch for 30 seconds. Let it go. Hold, let it go. I usually tell people do this in the shower. You can open up your labia and then massage on the outside on that muscle. That's where the urethra, clitoris, you could go in and then just like do circles. So it's kind of like if your neck hurt, right? People go like this.
Hmm.
It's the same thing. And I think that we forget that these are muscles and it's not wrong to touch your vulva, right? It's not saying that you want to be intimate with yourself. It's not saying that you're trying to arouse yourself. These are muscles. You're trying to
Hmm.
stretch, you're trying to bring blood flow, you're trying to calm the signals, just like we would do with our shoulder, just like we would do with our back, right? We can rub these tissues, and oftentimes they feel good, and not good in a sense that you will get aroused, but I mean, you can, and that's not wrong either. So that's just very important to state that these are muscles just like every other body part.
Yeah, I think it is really important to make that point. I think we could talk about a lot of these topics in a lot more detail, but we've probably run out of time today. So I wanted to ask a couple of quick questions about your practice. What types of patients do you see?
Yeah. We see, so I feel like our main population is pelvic pain. So unexplained pelvic pain, chronic pelvic pain really is our niche within the niche. We do see people pregnancy, birth prep, postpartum, other rehab, pain with sex, infertility, and their fertility journeys. Male pelvic pain, we really see it all, but we really focus in on the pain aspects and where you're at in your journey.
Mhm.
Right, and
Yeah,
whereabouts? Okay, sorry, go on.
sorry, I was in pelvic pains like endometriosis, interstitial cystitis. It could be chronic bladder syndrome. It could be on the flip end symptoms, so abdominal pain, vulvar pain. It could
Constipation.
constipation, period pain, right? So we can do symptomology pelvic pain or actual diagnoses pelvic pain.
Okay, that's great to know. And where is your clinic located, and how can people get in touch if they'd like to make an appointment?
Yeah, we're based in Costa Mesa, California. And then on our website, we have a bunch of just free education. Our website's called tonicandphasic.com, TONICANDPHASIC. I say that because it's so like people are like, wait, what is that?
Yeah, I can understand. We'll be sure to put the link in the description as well so they can find it directly.
Okay,
Yeah.
perfect. And on there, we have, like I was saying, blogs, free handouts, our contact. And so we'll go to our patient coordinator. And if it's specifically towards us, she'll give it to us and we can get in communication. We have online booking. So we do virtual visits for people. We call it pelvic health coaching, where we coach you through your pelvic experiences and try to navigate the medical field for you so that you can get to the right providers, get the right treatment, and then even coach you through the things that we can coach you through.
Great. Well, this has all been very insightful, and I look forward to sharing it with our audience. And thank you so much again.
Yeah.
Yes, thank you so much for having us.
Yeah, thank you for having us. It was a lot of fun and a good way to get my brain going right in the morning. So I love it. Firing questions, I'm here for it.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.